Okay, we're back. And then we're going to move on to, we're still in early pregnancy, what we call gestational trophoblastic disease. There's what happens with this is we've got a trophoblast, and we know that that's the outermost layer of the embryonic cells. It gives rise to the chorion, and we know the chorion, if we go way, way back in the first week of school for this class, the fetal membrane is the closest to the intrauterine wall that gives rise to the placenta and continues as the outer membrane surrounding the amnion. It's the inner of the two membranes that form the sac containing the fetus and the amniotic sac. So, what gestational trophoblastic disease, or GTD, you'll see it. Acronym for it is GT&D, is gestational trophoblastic disease. It's the pathologic proliferation of these trophoblastic cells. They don't do what they're supposed to do, and includes a partial or complete hydatiform mole, invasive mole, and or a cancerous choriocarcinoma. And there it is, proliferation of the trophoblastic, when I just explained to you, cell, and the embryo dies because of this. They're like the baby blasts of leukemia. They're the ones that are proliferating. They're not supposed to be at the rate that they are. And so the embryo dies. And again, looking at your PowerPoint that I've posted for you, you can see this picture here. It looks like fluid-filled grape-like vessels. So that's what we see instead of a fetus. Again, this is called a hydatiform mole. It's a condition which a proliferation of trophoblastic cells results in the formation of placenta characterized by hydropic grape-like clusters or fluid-filled. And so this is what we see instead of a fetus. Significance of the disease for women who has it is the loss of the pregnancy. That's what happens. The baby does not develop. And the possibility through remote of developing cancer. It's a form of cancer from the trophoblastic tissue, but we used to think it was always going to turn into cancer. It doesn't, not all the time. It just depends. So anyway, and then there's another picture that follows that you can see. They're almost like you can see through them here before we go here. It's after this slide. They look like, to me, grapes, but they're fluid filled, and that's what it looks like under a microscope and via the ultrasound. And there's another picture of that. Okay, so now we're done with early pregnancy, and we're moving on to late pregnancy. Late pregnancy bleeding almost always refers to something's wrong with the placenta. So we're going to look at two conditions here, and you've heard me talk about them kind of from the beginning of time. And if you've been in the hospital, you've heard of them because it happens. It's more common than you think. Placenta previa versus placenta abruption. So placenta previa occurs when the placenta abnormally implants in the lower segment of the uterus. So it's going to cover that cervical os or the door out. And that's why it's not that great, because the baby can't get through it. Now, if there's a partial, they measure it in percents, which we're not going to look at in this class. But if it's just a partial placenta previa, a lot of times the babies can deliver vaginally. But if it's totally covering that cervix, we know we cannot deliver the baby. It can't go through the placenta, right? So again, for previa, it implants in the lower segment of the uterus near or over the cervical os instead of attaching to the fundus. You know, the placenta should be high, implanted high on the side or at the top, or if it is on the side, high on the side, not in the lower end of the uterus. Abnormal implantation results in bleeding during the third trimester of the pregnancy, because we know that the placenta is loaded with blood, and it's that's part of its function, is to send blood through to the baby, and then the umbilical vein brings it back. Especially as the cervix begins to dilate and efface. The cause is unknown, 1 in 200 women, so you can imagine how common it is. Major complications include maternal hemorrhage and fetal prematurity or death. They can't get through that. It's not going to work. It doesn't dilate normally like the cervix. It's blocking that from happening. So risk factors for placenta previa are previous placenta previa, uterine scarring, previous C-section, sometimes several curettage where they've gone in, DNC, dilation and curettage, and then endometritis. Maternal age greater than 35, unfortunately, they get everything. Multifetal gestation, which makes sense because there's no room to have the placentas in the right spot. And multiple gestations are closely spaced pregnancies. And so the assessment would be you get painless, bright red vaginal bleeding. It's painless. It does not hurt them, but all of a sudden they're bleeding. Bleeding that increases as the cervix dilates because of where it is. It's a soft, relaxed, non-tender uterus with normal tone. Very important because these two are very different, to remember that. I'll say it again. It's a soft, relaxed, non-tender uterus with normal tone. There's no pain. The fundal height is greater than usually expected for gestational age. And probably because the baby is being pushed up there instead of being, with the head down where it's supposed to be, because that's where the placenta is. The fetus is, again, in breech, oblique, or transverse position because they're pushed out of the way. Palpable placenta, decreasing urinary output, vital signs are normal. Assess bleeding, leakage, and contractions, counting pads for bleeding amount, and an abdominal examination needs to happen. So we need to do, again, assess the fundal height. Nursing interventions are bed rest, nothing inserted vaginally. Whenever there's vaginal bleeding, they do not want to do a vag exam ever. IV fluid should be administered and, as precaution, just in case they do start hemorrhaging. The corticosteroids are given for lung fetal maturation always if they're going to take the baby early. They're bleeding. It's a placenta. A baby might be 34, 35 weeks. They're going to give steroids. That's for the fetus, not the mom, for fetal lung maturation. And blood replacement if we need it. Okay, so now let's look at abruption. Abruption is much less common, which is a good thing because I think it's a worse condition. The incidence is 0.5 to 2% of all pregnancies, but in knowing that, it accounts for 15% of perinatal mortality. So what is it? An abruption is a premature separation of the placenta from the uterus, which can be a partial or complete detachment. And that is an obstetric emergency. It's not like the previa where it's just hanging out in the wrong spot, but it's still functioning normally. It is abrupting, meaning it's in a very, abrupt way, quick way, it is starting to come off of the decidual plate where it's not supposed to. So you can imagine what's going on with the fetus. And other things are going on with mom too. Mom, with the assessment, will have sudden onset of intense localized uterine pain. It's extremely painful. When they come in with an abruption, we know before even doing an ultrasound because their abdomen is stiff, hard like a board. It's not soft, and they are in intense pain. But we have to do an ultrasound very quickly, and then you have to call any OB in the house or their OB, and it's an emergency. They have to perform. Doesn't matter what age the baby is. If you've got time to get the steroids in, I do it for the lung maturation if they're not 38 weeks or older. And but we know if the placenta stops working, the baby's going to be stillborn. So this is a true emergency. Let's see, what else can I say? Premature separation of the placenta from the uterus. It can be partial or complete. Hopefully it's partial because it gives us time to get ready to get the baby out. This occurs after 20 weeks gestation. It's usually found in the third gestation. Significant maternal and fetal mortality if we don't do something. It's more frequent in pregnant women who smoke, premature rupture of membranes, and have hypertension. So when we go into the next segment in this lecture of preeclampsia and pregnancy-induced hypertension, they are more apt to get an abruption also. Cause is unknown. Coagulation defects such as DIC is often associated with moderate to severe abruption. Again, once you get in this cascade, because there's so much blood in this area, anything can happen, and it does. Okay, let's see. Key factors that can happen: maternal hypertension, I think I already said that. A blunt external abdominal trauma. I worked in a trauma center, so we saw a lot of these that weren't even our patients because I was right off the 55 freeway off of there when it's raining and people don't slow down, so forth. It can be a vehicle accident. There can be abuse going on where women are knocked down a flight of stairs. Any of this trauma can also knock that placenta off that decidual plate. And so we're looking for that. Cocaine abuse, it's it constricts everything. Previous incidents of abruption placenta, cigarette smoking, and multi-field pregnancies again. We're not only going to see a firm, rigid uterus that once we get an uterine not hypotonic, which we're usually worried about after delivery, it's hypertonic. We're going to see fetal distress, symptoms of hypovolemic shock in mom. Interventions, what are we going to do? Bed rest, no vaginal exams again, administer blood products and fluid volume replacements. We need to maintain that client's urine output at least 30 cc's an hour. We need to know an H&H. We need blood work. We need oxygen, and we need to get the baby out. And again, very important, somebody's got to be thinking about the baby when all this stuff is going on, and corticosteroids need to be given IV to promote the fetal lung maturity. They'll deliver the fetus vaginally if it's a term infant. Remember, this isn't the previa where it's blocking the door. It's just abrupting. Not just, that's an emergency, but it's abrupting. So this one can be delivered vaginally. A C-section if there's fetal distress, and it depends on how big the abruption is and how far along it is. C-section, of course, is going to be contraindicated if the person's already gone into DIC. So this can turn into a real circus. And here's a good picture here. This is one I was able to get, is that you can see the abruption where you've got this big blood clot because it's coming off of that decidual plate. See how these are all on a plate? Well, that one's not. That's in the wrong place too. This one. A is basically the normal one. Oh, there it is, normal. B is the placenta previa. It's over the door, so the baby can't get out, and that's why the babies are in transverse, oblique. They're all over the place. And the fundus is much higher because the baby's up here. Some parts of the baby are up here instead of the placenta that just lies flat. And then accreta, we haven't talked about yet, but accreta is the one that grows right into the wall of the uterus, not on a plate like this one. There's a little plate in here, that decidual plate. And so with this one, because it grows into the wall, very, very high risk of hemorrhaging at delivery. And so they have to go into surgery and have a hysterectomy. It has become part of the uterus, so they have to have a hysterectomy. And then here's the abruption where it's coming off of the plate, and you see a huge blood clot back there. So very, very large chance of bleeding. Okay. What are we looking at here? Implantation of the cervical os, less functional placenta, blah, blah, blah. Extensive hemorrhage, dilation of the cervix disrupts the placenta, yes. And there are different types of placenta previa, which I've got some pictures of in your slide. Again, they don't know why placenta previa happens, but it is associated with women who have scarring of the uterine wall from previous pregnancies. So the placenta just floats around to where it can attach. Women who have fibroids or other abnormalities of the uterus, that makes sense. Women who have had previous uterine surgeries or C-section deliveries. Older moms over the age of 35. African American or other minority race mothers. Cigarette smoking, and placenta previa in another delivery. Okay, we're going to stop here and we will finish with this before we go into hypertension. Okay, see you in a little bit.